Hello! Now we get back to my country, Portugal. I'm proud to present two of my compatriots, friends, and colleagues that represent Portugal abroad, lecturing around the world on the subject of implantology and tissue regeneration, Dr. Bernardo Correia and Dr. Filipe Lopes. They both graduated at the Oporto University and are members of BTI's International Scientific Committee. Nowadays, they are also experts on the Dental XP community and founders of the EIT Expert Implant Therapy Study and Research Group. In the past years, they have been sharing the stage in some of the most renowned congresses and universities worldwide and have been authoring several publications. Bernardo and Filipe have their own exclusive practices focusing in implantology, aesthetics, orthodontics, and oral rehabilitation. They will be talking today about a subject and a thematic that will be very interesting for everyone, called From Bone to Ceramics, New Perspectives on Socket Shield. This is one of the most interesting and updated subjects around implantology and tissue conservation. I am sure you will have the best of fun. See you soon in a couple of hours.
Hello everybody, my name is Bernardo Miro Correia.
And I am Filipe Lopes.
We are from Oporto, Portugal.
Yeah, and it's really an honor to be here in the second edition of International Aesthetic Masters.
Such a great and amazing event among such renowned speakers. We are really proud of it, to be part of it, and of course we need to thank João Borges.
Yeah, and of course to thank Rui Pereira da Costa, because of their effort this is being possible.
Yeah, and for us it's indeed an amazing opportunity to share a bit of what we are doing.
And really what brings us here today, I should say, Bernardo, is the smile.
Yes, for sure. You know, I think we all agreed that smile, to improve their smile, is one of the main reasons that brings patients to our clinics.
Yeah, because they know, and everyone knows, and even it's supported by the literature, that when you are able to improve your smile, well, you improve your entire life.
Yeah, for sure. And according to Bill, we can even have more success and have, well, reach further in our career. So that's why people indeed want to get a new smile, a better smile. But you know, it's not only about teeth, getting good teeth to the patient. Sometimes we need to do a little bit more, don't you think, Filipe?
Yeah, it's challenging because sometimes what patients want are some technical details, but it's a lot more than that.
And more than that, you know, they see that some friend put some veneers and they get to our clinics and say, "Doctor, I want veneers." So what we know is that sometimes it's not that easy. It's not just preparing the tooth and place veneers.
Yeah, because we have to integrate everything. And we take this example. What do you think of this, Bernardo? Would you transform that canine into a lateral incisor?
One thing for sure you know, and we all know, is that it's usual when we have, you know, these agenesias of lateral superior incisors. Many times we can change this canine into a more lateral incisor shape, but we know that this is an unbalanced tooth morphology. So what do you think is the best option on this case, Felipe?
Well, I think we have to consider several aspects, and as you well said, it's very, very difficult to transform a canine into a lateral incisor in a pleasant aesthetic way. And also, you got function and occlusion. So you have your arch, the perimeter of the arch, and the occlusion is a little bit compromised. Would you say that?
Yeah, for sure. We cannot, or we should never neglect function to
Only to aesthetics.
exactly only to benefit aesthetics.
So in this case, and we also love to be conservative. And she has the wisdom teeth, and they are, well, more or less well positioned. And we have to gain space.
Yeah.
What are the options here?
It's indeed, again, a challenging situation because, as we know, most orthodontics are going to be prone to extract teeth, and we know that this will enhance, the buccal corridors, and also we will get not such a wide smile. So, of course, we need to think in all aspects when planning. So we are not trying to benefit the aesthetics from one hand and neglecting it from the other. On the other hand.
Yeah, so that's the challenge of this case, for instance. We have to really to create space for our lateral incisor and to balance a little bit the smile line and the gingival display, everything. So
without extracting teeth.
Without extracting teeth. We're going to try not to extract teeth. And so utilizing mini implants, we know that nowadays we can do a lot in terms of space management.
Yeah, sure. Skeletal anchors, in many options available, they indeed revolutioned the way of tooth movement within the bone. And like in this case...
Yeah, we did create the space. Thereafter we could place an implant to try to replace the lateral incisor into a natural way.
Yeah, and even better than just placing the implant is adequately place that implant, because we know if we do not control that space, that prosthodontic space correctly, we would never be able to finish with such lovely interdental and implant papillae.
Yeah, and that's very, very important to end the case. And so with the orthodontic treatment, we prepare the case, and we're now ready to go for veneers. That's what you wanted.
Yeah, so it's very important for us and it will be our tonic within these presentations, to talk about the planning, because a wrong decision can totally take us in the wrong direction and end up compromising the aesthetic result. So the patient indeed wanted veneers, but she didn't know at the time that she needed to first undergo through an orthodontic preparation, and only after that she would be ready to get those so desired veneers.
Yeah, that's the way to go, and so that's what we did.
Yeah. So, of course, we are here to try to provide our patients with beautiful veneers, like in this case, beautiful teeth, but we know again that this is not enough.
It's not only about teeth, and that's always our challenge,
because
the difficulties that we find.
And as we all know, teeth are not enough to provide good aesthetics. We cannot forget that teeth are imbibed in the soft tissues. So even in smiles that don't show, look at these small pink triangles.
Yeah, you can see the papilla over there.
These papilla make a whole difference. They play a very important role in the smile. So we cannot neglect the pink aesthetics.
And also, we're not only just talking about soft tissues, gingival soft tissues. We also are talking about facial soft tissues. We got to integrate everything.
So, for example, in this situation, we can clearly see that although we manage to rehabilitate the case with nice ceramics, with veneers and implants, it is clear that, again, on this superior lateral incisor, the soft tissues
Yeah,
Texture and volume is not adequate.
we got a problem over there.
And the big problem about the soft tissues is that this superior band, this transition zone, which is a 3 to 4 millimeter band of soft tissues, that's where all our efforts.
That's the key issue. When you're not good enough in managing those 2 or 3 millimeters that you talked about, we're really in trouble, and patients are not going to be happy.
Yeah, because now we are talking in a different way. In here we have an implant, and dental implants, they are not, as we know, as easy to achieve a good aesthetic outcome as with natural teeth. So in here, although we have a nice and well also integrated implant, we also have the interdental papillae, but the soft tissue shape and texture are not alike.
Yeah, contour and texture here is really to be improved.
So what we need to know is that when we talk about implants, we need to care about 3 major guidelines. We call it a 3D approach from regeneration. We need to take care about the X, the Y, and the Z factor. The X is the soft tissue factor, and we need to end up with nice color, texture, and volume of the soft tissues, according to Furhauser.
And we cannot forget about the bony peaks, because the bony peaks are going to be a crucial point for you to support the dental papilla. So,
and we are all aware about this famous publication in 2002 about Tarnow's major and golden rule of the 5 millimeters distance from the bony peak to the contact point.
Yeah, so we must keep that on mind every time we're talking about implants.
If we want papilla, we need to obtain bony peaks so we can be within the 5 millimeter range of distance between the bony peak and the contact point. And also, you know, the bone around our implants, and according to Professor Welly Grunder, we all know also that our goal is to obtain a minimum of 2 millimeters thickness of bone around our implants. And we should also know that that should be a nice guideline for us to be predictable on obtaining good aesthetics.
Yeah, I would say that is a very, as you mentioned, that is a very important key point, is that you have at least a thickness of 2 millimeters, because it's going to be disguising the gray that you get from the implant. So it's very important that our goal from the beginning, from the very start, is 2 millimeters in thickness at least, I would say.
So as we were saying, we need 3 major goals if we want to succeed, ending up with that 2 to 3 millimeter soft tissue zone, the transition zone within the aesthetic range. We need to obtain minimum of 2 millimeters thickness of bone. We need to succeed regenerating or maintaining the bony peaks, and also the soft tissue that we need to have at least 2 millimeter thickness of soft tissue and adequate contour, texture, and color. So,
yeah, and I would say also that when it comes to soft tissues, we want also immobility, and we're going to be talking about that.
It's about the keratinized tissues.
Yeah.
So what we know, like in this case, is that if we fail on one of these guidelines, and in this case we fail on the X factor, the soft tissue factor, we will need to manage the collapse of the tissues within the tissue zone, the transition zone.
And above all, when you fail on the transition zone, we must know that it shows.
Yes.
The patient will show it when it smiles. So
and it doesn't matter at all if we have the most beautiful morphology and color or ceramic of the teeth.
Yeah.
If we don't have an adequate transition zone, we'll have this situation like we can see on the left picture. And then we will have to undergo with more complex and less predictable treatments.
Yeah, there are good options to try to solve those kind of problems, but still they imply more complication to the patient, more suffering, etc., etc.
So no doubt that the best approach is prevention. If we can prevent collapse within the transition zone, we will be closer to succeed on reaching a good aesthetic outcome with our patients.
Yeah, we'll be much closer to being natural, to emulate the natural.
Totally, like in this case. So what is our sequence? The first thing we need to do is, of course, to try to undergo through a digital or a wax-up, the traditional wax-up. So from there we can try to make a mock-up and try it on the patient.
And just not, Bernardo, what do you think? Because I know that you've put a lot of time in designing those teeth.
Yeah,
it's
for
not
sure.
only taking them to the lab. You got to
Exactly.
participate as a
Totally.
doctor, as a dentist. You got to participate in designing those teeth.
Exactly.
Don't you think so?
Totally agree. We need to be part of it. For us, we think it's a little bit beyond that digital concept that many people, are applying. We like to be in closer interaction with the patient, with the lab, and with within the teeth.
We also love to fuse both technologies. I think it goes a lot through the mock-up, and also that you then can incorporate
the best
digital,
from both parts. Exactly.
the best from both worlds. It's going to be better.
Either you go traditional or digitally. The important thing is that we can establish, our transition zone with the provisionals.
Yes.
And from there, we know we are guided from the smile, from the face of the patient. And by doing that, we will be able to guide our implantology in the best way, according to the smile of the patient. It's not only the prosthodontic, but it should be a smile-guided implantology.
I would say that facial references and smile references are of utmost importance to do the planning. That's what it's all about.
Totally agree. Totally agree. So now that we set our transition zone, which is crucial, as we've been seeing, to obtain an adequate aesthetics.
Yeah, and in this case, our goal is trying to preserve, not spoil what nature has for us.
Yeah, first of all, we improved. So we altered the tooth shape. We also reshaped with some gingivectomy to enlength the clinical crowns, to balance.
Always a lot of multidisciplinary work when you say so.
And when it's set, when we have the facial integration of the transition zone, then we are ready to start planning.
Yeah, and when we plan, sometimes we have a lot of surprises, like in this case.
Yeah, because if we see again the initial situation, we put a lot of effort. So now our biggest goal should be not to spoil this.
Yeah, but look at this CVCT. Look at that buccal bone. That buccal bone could be an issue because it's so thin. What are we gonna do? Are we gonna place an implant? Just placing an implant there?
Yeah. We have a very thin buccal bone. We have an endodontically treated tooth, so there's a big chance of having some ankylosed areas in there. So it should be very easy to, even with a traumatic attempt to extract this tooth. Yeah, it should be easy to take some buccal bone with the teeth. Don't you agree, Felipe?
Yeah, even being cautious, that could be really, really difficult to extract this teeth and maintaining that bone, which is so thin. And not only the buccal. Even in this case, we have the palatal and the buccal corticals are both thin, which is a risk factor even bigger than usual.
It's a huge risk factor. So in the minimal, we should be considering to lose the buccal cortical and maintaining part of the palatal, and that should be like a socket type 2 situation. Easily. And we can have like a cybric type 3 situation with horizontal and vertical loss after healing.
And we don't want that.
We totally don't want that. So what options, Felipe? That's why we need to really think about what to do.
Yeah, that's why it's so important that you discuss this with your colleagues. And I'm lucky enough to have him, and we can discuss all these complicated cases.
And
So
the
I
sl-
would say this is a good option.
Yeah, the slide jumped a little bit. There's
Yeah.
no need to put it
Yeah, we
backwards.
didn't want that to
It was a
happen.
bit too fast. Yet we know today that, for example, the partial extraction therapies can be a very resourceful and useful tool exactly in this kind of risky situations.
I would say that is absolutely game changer. At least for us, it has been for quite a few years now, and it's something absolutely incredible, especially when tackling this kind of cases, which are very, very difficult, as you saw.
So we managed to maintain the transition zone, to maintain the aesthetic pink.
And when I think of the CBCT, the initial CBCT, and I can see all that convexity all around the dental implant.
That root effect.
Wow, the root effect is beautiful.
And this is
It's
game
beautiful.
changing for sure, because with the socket shield, it is, I believe, the only surgical technique that really can maintain this root effect, this root convexity
I
in the buccal
completely
aspect.
agree with you. I completely
So
agree
after
with you.
we have succeeded to maintain our projected transition zone, of course we just need to go and follow our wax up,
Yeah, now we are ready for veneering.
and now we are ready for veneers, placing that implant, and of course finishing the case in a very acceptable way.
And making, above all, in such a difficult situation, making the implant disappear in
Totally.
between the teeth.
I
which
totally
is-
agree. And if we show you the next picture, I think you also will agree. Oh, this was fast again. So a very biomimetic approach.
Yeah, very, very biomimetic approach.
But the next case that also we just pressed the key a little bit too far, but the next case is a case that we are not able to do socket shield because this tooth is already loose.
Unfortunately, there are cases where we would love to be able to do a socket shield, but we can't.
We simply can't. We have a loose tooth, we have some infection and granuloma and granulation tissues, we have a socket type 2C, which according to Stephen Chu is when the bone resection is until the apex level or beyond it.
And the gingival aspect of the defect can wrong you because it doesn't look that bad. And as you can see here, despite it's bad, when you see the picture and you compare it to the CBCT, wow, you have no buccal plate at all.
Not at all. And this can be a huge issue. So how can we manage this transition zone?
Yeah.
Even harder, how can we improve this transition zone? Because we see at the patient's smile, and she's a very young patient, she was 23 years old at that time, and if we fail, we are going to,
It's disaster.
she will have lots of years to remind
Yeah,
how
it's
bad we acted.
disaster. And you can see that the gingival margin actually doesn't look that bad but when you remember the CBCT, it's like 10 to 11 millimeters without bone. So
And that's exactly what we need to talk within this next slide, is that we have so many options, treatment options, but the bad planning can be very bad for the patient. In the best situation, she can start showing the implant's neck, and you remember she had a high smile line, so she will show that gray and that color. Felipe, don't you agree?
No, gray.
Nobody
is not good.
likes
Gray
gray.
is not good.
But if we plan really bad, since we've seen it's a huge buccal bone defect, we can end up with a case similar like this.
Yeah, if we don't manage this case properly, we will end up on the right picture for sure.
Which is also something that we are
so good planning is essential.
very sure that the patient will not like. So again, so how can we manage this transition zone? Is it just placing an implant enough?
No, I wouldn't say I wouldn't say so. It's going to be so much more complicated than just placing an implant.
Totally. So that's when we totally believe that as an option that we should go interdisciplinary.
Yeah, do you think you could somehow only extract the tooth and do regeneration? What are you thinking about in this case?
Well, I totally believe that in situations like this, she's a very young patient. She has a high smile line, so all your mistakes will show. So this is a zero tolerance area. So we should take advantage of all things that can really help us.
So you wouldn't go for, and I can see that she has a scalloped gingival pattern. Well, that could be a tragedy, in fact, if you went directly to surgery.
Yeah, for sure. I totally agree. So let us reveal what we believe it's a good approach on a case like this. So orthodontic extrusion.
Yeah, Salama has taught us.
Bone grafting, delayed implant placement, and this is crucial. If we try to go for immediate implant placement, immediate post-extraction implant placement,
Yeah, it's going to be a
this
mess.
can be catastrophic.
Yeah, in this case, you can't do
It's
that.
not that it doesn't work, but how predictable can it be? Are we willing to pay the price of that risk?
Yeah.
Is the patient willing to pay?
It's
that
not
risk?
worth it. It's not worth
It's
it.
what we agree.
That-
It's not worth it. So we go and we start with the orthodontic extrusion. And like Felipe said, it's been described since 1993, published by the Salama brothers. And it's a tool that sometimes is so often, forgotten, don't you believe, Felipe?
Yeah, I think we always should have in mind that orthodontic treatment, even if it is a simple orthodontic treatment, can be part of your tools to solve a case. As in this
Let me
case.
correct you. It should be.
Yeah, it must be.
It must be.
It
And
must
looking
be.
here, just by installing 4 brackets, we can improve so much the starting point.
Only 4 brackets, and it's amazing that your starting point, how you just improved it so much.
So when we improve this starting point, well, now we are ready for the next step. The step that most people would be jumping into.
Yeah, it's
start,
a temptation.
The temptation to
sometimes,
start with the
yeah.
bone block.
Yeah, but you can see that even after orthodontic extrusion, there's a huge defect over there. But you brought all the gingiva and part of the bone with you, so you decrease the defect.
Totally. And we also know how hard sometimes it is to bring the gingival line down 1 millimeter or even 2 millimeters like we did on this situation.
No, I think
It's
it
really
was
hard.
it was about 3 millimeters here. You did bring it a lot to the coronal, and
So-
that's a good starting point.
Now we are ready to start dealing with our bone factor. So we do bone blocks. We also combine the using of xenograft with cellular biomodulators like
Yeah.
PRGF,
Always bioenhance the grafts.
bioenhancing the grafts,
with the PRGF, and that's the result.
and there's
I
the
mean,
result.
You got almost from the palatal cortical, and now you got a nice volume of bone where
Yeah.
you can place your implant.
Totally, but it's not that nice, not that nice, because these traditional bone grafting techniques normally of course with the flap tension, they tend to resorb a lot of the most coronal part of the crestal area, and so that's why this was our ECG during the surgery, because we were really
Listen,
a bit in panic.
This can be a rush because you're working on a site which is much better now because of the block bone graft that he did. but still it's a very, very tricky site for you to work on.
Totally. It was a cortical bone, so no elasticity at all. So we had to thin it with drills and combining the use of drills to reduce the bone thickness combine it with the motorized expanders.
Yeah, which is a wonderful tool for those difficult situations, the expanders.
And we managed to finally and very gently place the implant.
And also, the implant that was placed was a tiny implant. And this is so very important because we sometimes tend to go to larger implants, and this is crucial on the aesthetic area, that you provide the tissues with those, remember, those 2 millimeters of bone.
Totally.
So,
the implant selection.
implant
Very
selection
important.
is, you must be
All details,
very, very
all
accurate.
details matter.
Yeah, very accurate.
And since all details matter, even in 2006, even though Thomas Linkevicius hadn't even published its amazing articles about, the minimum soft tissue thickness around the implants, we already had that clinical sense that within the aesthetic zones we always wanted to enhance the soft tissue thickness, so we always did a connective tissue graft.
Yeah,
at the same time. Like
we're
standard
obsessed. We're obsessed by that,
and that's why we are such big fans of Tommy Linkevicius.
Yeah, because he really conducted his study was the first controlled clinical trial on thickness of soft tissues and how they influence bone loss.
Yeah.
This is very
How
important
they
knowledge for us
they can
nowadays.
influence the bone stability around
our
the implants.
Yeah, that's very important.
And by doing all these procedures, this interdisciplinary approach with the orthodontic extrusion, with the bone blocks, with the connective tissue grafting, we were able to control the three factors.
Yeah,
the
and
bone,
then again, look at the root effect. Look at the root effect, and when you remember that you hadn't buccal plate at all,
Yeah.
it's incredible.
it was a nice achievement.
Yeah.
Using the adequate tools, with the adequate technique selection, we managed to regenerate bone, soft tissues, and not only soft tissues, even the Z factors.
Bernardo, and what do you expect from this case as time goes by? What do you think?
We will see in a minute.
Yeah.
All right. Let us not jump into the slides. Very important to talk about the Z factor. As Tarnos showed us since 2002, if we manage to maintain the bony peaks, we will for sure obtain papilla between the teeth and implant.
So that's why it's very important that you yourself and your lab technician, you must locate
Totally.
your contact points.
Exactly.
It's up to you. You're the one who's going to be deciding that. You know where the bone is. You know where you want your papilla to be.
Communication between lab.
It's
and
very important that you communicate well with your lab in order to achieve this beautiful
But
results.
if we were happy with this case, the picture that made us even prouder is not yet this one, but see, this was the Bayes line on the left picture. Look how we could change the transition zone. Look at the papilla level.
Yeah, it's
And
beautiful.
this is really hard to maintain, especially with such a big bone defect that was underlying at the initial situation. But like I was saying, the picture that I'm more proud of is this one, because after 10 years, and we were talking about, how long,
Yeah, what
how
could you
predictable
expect?
can be this case within time. And one thing is for sure, if we take care of our three major guidelines, the bone factor, the soft tissue factor, and the bony peaks,
Yeah,
also,
it's going to be success, yes and
it's
yes.
going to be stable. It's going to be
and
stable.
stable a long time, which is...
And if we see the CBCT post-op control also 10 years, we can see how stable tissues are, and it's amazing.
It's beautiful. It's really beautiful, and it's rewarding that you can see those results lasting 10 years after
So
placing
we will
the implant.
control the case, and luckily within more
10
10 years,
more.
we hope we can be still happy showing this case and controlling this case.
No doubts.
Well, sometimes it's not about improving the smile. It's that patients cannot smile at all.
Yeah, sometimes it's difficult. And when they come to us, they are desperate because they want to improve.
And we are not very, amazed by it because we can really easily see this huge aesthetic issue that she has.
Yeah, it's the deformity, and you really have a very difficult challenge to tackle. You got a socket type 2 and a socket type 3. It's important that you diagnose the kind of socket you're working in because it will condition your work.
Yeah, totally agree.
What would you do here?
Yeah,
Bernardo?
I think it's, rule number one, first thing is establishing the socket type, because after this, or this choice or this diagnosis totally will determine the treatment.
Our action.
Our
Our action will be conditioned by the kind of socket that we have. And we basically have, and it was described by Elian and also Shu and Tarno, we have 3 types of socket. Can you,
Yeah, well,
do you want to
the
say something
most
about it?
desired one is the socket type 1. This is the ideal socket because we don't have bone recession and we don't have any kind of soft tissue recession. So this is the ideal socket for us to go and place the implant. The tricky one is the socket type 2.
Yeah, and also you have the socket type 3, which is the most difficult one. But then again, with socket type 3, you can see the defect.
Yeah.
So it reflects on the soft tissues.
A bit.
You see it.
But it's crucial, Felipe, it's crucial for you to understand that why the socket type 2 is the tricky one. Because it looks like a socket type 1, but the bone underneath, we have recession. So it will totally heal in a different way than the socket type 1. The socket type 3, of course, everybody can be aware immediately because we have both bone and soft tissue recession. That is a tricky situation or a hard case to solve.
I'm happy that you mentioned that because that's exactly that. And that's why Shu he made a sub-classification
Exactly.
with type 2, A, B, and C. Because that's what Bernardo said. The tricky thing is that type 2 usually looks like type 1, so you can't see. But as you can see there, you have a small recession on the buccal and you still have a good level of gingiva. You have a bigger recession on the buccal on type 2B, but gingiva is okay. And on type 2C, it's really a type 3 socket, but it looks like a type 1. So
Exactly.
very, very tricky when diagnosing.
And especially a bad planning, a bad diagnosis, a bad planning in this situation will for sure lead us to a bad aesthetic outcome.
Yeah, and we don't want that. One of the things that we know for sure is that on socket type 2 and socket type 3, we don't want to do immediate load. Do you want to do immediate load on there?
Not predictable.
Not predictable. We saw on the first case, on the case where we did on the lateral incisor, the extrusion, orthodontic extrusion first, we saw that we had a socket type 2 with no buccal bone at
Yes,
all.
and especially according to Danny Boozer's publications, socket type 2 and 3 always require for delayed implant placement.
Of course, so remember that. What are the options in this case? What would you do?
Yeah, that's when we need to start thinking about
Yeah.
the odds and options.
And what would you do?
Well,
in this case, where would you start?
We've seen an option, the orthodontic extrusion.
Yeah.
It would be nice maybe to try to pull that tooth down, bring some...
Would
some
that
soft
be
tissue.
your first choice?
I would really like to take advantage of that.
Well, agreed on that. I think both of us, we would go for orthodontic extrusion.
And some blocks, because we have some huge defects, so for sure a block graft could be handy, to take care. Do you remember the bone factor? So
Yeah.
we want to take care of the Y factor, the bone factor.
X, Y, and Z.
We don't have bone, so we need to block graft to add bone to the equation.
Yeah, it's important. So it's important that you keep in mind that you're not following only one road. you so many times have to go for several procedures in order to achieve the kind of aesthetics that you want to achieve.
Yeah.
But then again, what happens to patients? I don't know if your patients are like that, but
They sometimes they don't want to follow the correct road. You know, they totally block us on that correct path. So we need to start thinking again. You know.
yeah, if there is, you should never compromise your situations or your patient's situation because of that. But the fact is that sometimes, and this was the case, she didn't want orthodontics, she didn't want to go through major surgery of block grafting, not staying without
No,
teeth.
she will make it easy on you. I don't want to stay without teeth. Okay, so
Okay.
even easy. And I
Yeah.
don't want a removable denture. Great. So
Come
now
on.
she's
So,
really making things very hard for us.
yeah, it was really a challenge. But then again, we thought and planned the case, and we're going to see how we did it. And on both these sockets, we decided to place the implants. The first thing is to try to place them in a proper position.
Totally.
What would you think
Yeah,
in
exactly.
this case?
So that's why it's very important to first diagnose, you know, the socket type, and then to diagnose the bone availability. Bone availability will force us to place implants within the bone axis. And sometimes this can compromise our prosthodontic approach.
Yeah, and we always want to go for screw retained because of retrievability and also because it's a lot better in terms of prosthodontic maintenance and prosthodontic behavior, biomechanical behavior.
And this is an issue that is really, really, really a key factor when placing implants. And if we want to, of course, be aesthetic, if we place implants adequately, we are one step closer to achieving an aesthetic outcome. Don't you agree, Philippe?
Agreed on that. Agreed on that. And that's why
And sometimes it's just a couple of degrees of angulation change
it's
that makes the whole difference.
yeah, it's really 2, 3 degrees, 4 degrees. It's going to be a huge difference. That's why you can see those implant apexes over there, because we really tried to put them in order to obtain
Correct.
screw retained prosthodontic work. And
This is not only-
Thomas Linkevich's work. What do you think about this work? This was revealing.
It was another game-changing study, you know, because people were tending to place more and more cemented crowns, and now we are seeing that actually it's almost virtually impossible to adequately remove the cement surplus, and we all know that this is a major cause for mucositis and periimplantitis.
Yeah, and the relationship between periimplantitis and cemented crowns, wow,
It's huge.
That's amazing. So
And
we
this-
want to run
don't-
away from
exactly. We don't have time to go through that, but we really invite you to check this Thomas Linkevich's study, because it's really mind-changing to see how much cement we are leaving behind, even when we control with periapical X-rays, and we think there is no cement in there, but there's a lot of cement.
In this case, of course, we also have to do soft tissue management. You have to do everything. Remember X, Y, and Z. You're going to be rebuilding bone. You're going to be bioenhancing all the biology that you have, placing the implants, and also do soft tissue, proper soft tissue management. And this will allow you to...
It's outstanding. And on the picture on the left, we really, after we train our eyes, we see we have lack of bone, so the Y factor it's decreased. We have lack of soft tissue, the X factor is decreased. So we need to, of course, always include regenerating bone and soft tissues in our treatment plan. And only by doing that, we can get to this final outcome. Look at the amount, this incredible attached volume of soft tissue.
Yeah, that's the way for you to try to improve the biology around your dental implants and really make them stable through time.
And with an inter-implant papilla
Yeah, it was a tough case for you to
on
rebuild.
such a tough case. Exactly.
On such a tough case, you had to go through 2 procedures, and you were able to rebuild the interdental papilla. And I would say of course, it's not perfect, but if you remember the first picture, and if you remember that we went to immediate load, it's really game changing.
Yeah, it's I think under the conditions that the patient put us under
The limitations.
the limitations, we have an excellent outcome. Of course, we have a huge macro picture because when we go to the face,
Yeah, that's why we published
always
this on the
publish-
OXP.
exactly.
And it was 4 years ago. And when you go through the facial pictures, actually the patient, this is also about diagnosing and planning, because the patient had a gingival smile. She had a huge gingival display, and this is what allowed us to go for immediate load.
Exactly,
So-
because we will do some crown lengthening and
Then again, that's so important. You don't
improving
forget things.
improving the pink aesthetics, reducing the gingival display, and of course allowing us to go deeper with the implants and make a predictable immediate load.
And this is rewarding because this patient, we couldn't get a smile from her before starting treatment, and now she's always smiling. So
It's totally a life-changing situation. Felipe, get one slide back because you can see, no, with the Dental XP, you can see, though it's
it's an automatic.
one back. You can see this case in detail on the Dental XP platform, www.dentalxp.com. You can go under our names and you can see these lectures where you can see in detail all the soft tissue management procedures.
Yeah, because in here we
don't
didn't.
have
didn't have time to go through
So
that.
we invite you to get
Yeah.
there and learn some details on this very interesting and useful technique.
And we're pretty sure you're going to be enjoying it. We call it the wedge palatal graft. At the beginning is a graft of the buccal. You're grafting the buccal to provide for bone deficiency and also the gingival margin. That's what you're grafting. Salama is published now in
With a
2017
Anini brother.
the surgical veneer grafting with the Anini brothers. And in fact, I think it's a very, very,
Very similar.
revealing.
And a very similar concept.
Yeah, revealing concept, and it's wonderful because that's the way for you to compensate for natural labial plate remodeling after immediate implant placement.
Exactly.
So you could go through soft tissues procedures to try to do that.
And what if?
Yeah, that's our dream.
This is our dream. What if we could predictably maintain the transition zone? So maybe if we don't have to regenerate, to rebuild anatomy, if we can maintain the original anatomy.
Yeah, we know what was the effort to try to rebuild that interdental papilla.
Totally. That's
So
where we are leading at. We know that. Wait, this is too. We know that We know that rebuilding this inter-implant papilla was quite an issue, don't you think so?
Yeah, it was
not.
huge.
Don't you think so? You agree? It's
Yeah,
like more than think. You agree because you
I
went
think
through
it's
that.
a huge effort for everyone, for the patient, for all the staff, for you as a surgeon.
It demands
Of course.
a huge commitment
Yeah,
from
huge
everybody.
commitment from everybody.
So for sure, if we can maintain, this inter-implant papilla, well,
Yeah, if
we
you're
can
gonna,
make everybody's life easy.
yeah, if you're gonna lose both those teeth, those beautiful central incisors, man, you should try to
So we have-
preserve the papilla.
So the next case, we try to show you a similar situation. You can see that at the CT scan, we can see those cysts, those granulomas, those cysts that are, of course, resorbing a lot of bone,
And you can see a lot of the labial plate was gone.
especially here on the
On the
lateral,
right side,
yeah,
no.
on the left lateral incisor.
And that's a very, very big issue because you can end up easily on a socket type 3.
Exactly. I don't know if you are aware of Jonathan Dutoit classification from the crestal bone, and this is a class 1B. So we have a very thin buccal bundle bone, and again, this can be easily torn apart with less a traumatic extraction, or even just by removing the periodontal ligament.
Yeah, you'll get remodeling against
You'll get remodeling because we are cutting the major blood supply of that very thin papyrus-like cortical bone.
It's tricky.
It's tricky. So we can see that again in this aesthetic, in this major aesthetic area, we have a huge risk for facing, tissue collapse after bone remodeling.
Well, that's why it's so important that you evaluate the risk before you go there, actually.
Exactly. So what options, Felipe? What can we do in here? What would you do?
Well, we know that implant placement and immediate load was really game-changing. But on the other hand, you know that if you extract those teeth and you place implants, you're going to have bone remodeling, yes and yes. So we're going to be looking for some other alternative.
Our huge concern, our major goal should be for sure to maintain, that transition zone original morphology.
Yeah, it's beautiful. It's
because if we can get there, we know that we are halfway to success. And if we check Araujo and Linde's post-extraction implant experimental model, animal model analysis, we can see that when we do immediate implants, we can normally face, that buccal bundle bone loss. But again, if we see Hurzler's publications on socket shield technique, we can see that we can have a very interesting buccal bundle bone preservation. So this can be a technique very useful to get on that track to try to maintain, the original anatomy of the transition zone. Don't you think so?
Yeah, huge change. You can actually, what we're seeing is that you can wrong your body. He thinks that you have the tooth over there, and you don't have. You just have a part of the tooth, and you just have a part of the tooth, and
interesting.
Yeah,
and
very interesting.
At the literature, you can see other authors like Danny Ballmer, where also on this histomorphometric and radiographic analysis, he demonstrates that maintaining that buccal root fragment will preserve not only the periodontal ligament, has the integrity, has the buccal bundle bone.
And what will you have in the gap, in the space between the root and the implant?
Bone. Which is nice. Histology is confirming it. Mitsia's most recent study that is going to be published in 2018 is going to show us the human anatomy, human histology, showing that in between the root fragment and the implant there is bone formation.
Oh, that's wonderful, because that was a huge doubt at the first.
That was the biggest doubt. But one of the most important things that these histology pictures from Danny Ballmer that caught our attention was that, okay, it was great. They could demonstrate that the buccal bundle bone was preserved, was kept from resorption, but look on the right side with the yellow arrow, we have what happens to the lingual.
It's incredible. You have bone loss.
We have bone loss.
You have bone loss on the palatal. When you compare it to the buccal, it's incredible because it's a huge difference. I mean.
Yeah, so our idea was, why losing bone around our implants if it's useful? So that's why we remembered to maintain like a 360 degrees shield, root shield, that we call the O-shield. And the goal was, of course, to preserve the whole bone around the full perimeter of the implant.
And remember the difficulty of the case, because you had cysts also.
Yeah.
And don't think it's easy to completely remove those cysts. by only alveolar approach.
Yeah, not
What do you
totally.
think?
Well, sometimes in smaller situations you can, of course, do it. In bigger situations like this, it's very handy to make this semilunar incision like we normally do when we want to go for an episectomy. And of course, we gain direct access to, of course, make sure that all the inflammatory and infected tissues are removed and cleaned.
And look at the location of the incision, because then again, it's so very important that it doesn't get into the visible area when the patient smiles.
It's a very nice hint for sure. But that's where we were heading into. We want to maintain the integrity of our transition zone. So that's why we don't raise the flap. We don't want to touch this transition zone. So we get access through the apical level, maintain a 360 degrees root shield, and do the implant placement and the immediate load.
That looks nice.
And this is,
Do you think we're going to preserve all that volume?
well, pretty much sure, almost of it. Let me show you. So after healing, look at this.
Yeah, that's beautiful. I think this is what we want to see on our central incisors. Every time we have to place implants on central incisors.
My question is this. What do you think you prefer to undergo as a surgeon? Do you prefer to go through bone regeneration,
No
couple
way.
of major soft tissue grafting, or do some partial extraction therapy technique and get immediate access to a inter-implant papilla like this?
No doubt that the result speaks for himself, because this is really awesome. There is no other way that I know of where you can get such a papilla and preserve it so well.
Yeah, and especially we can see another very interesting details, because we have the clinical control of the situation, which is beautiful. We can see a very interesting, original anatomy maintenance. But check the CBCT. We can see that thin buccal bone is preserved.
Yeah, you got the root, the fragment of the root.
We have a huge root in there,
Yeah,
and that
still,
thin line,
yes,
it's maintained.
And another important issue is that when you're doing this kind of procedures, the socket shield, you also are obliging yourself to place the implants into the adequate position, because I'm seeing there that they emerge
pretty palatal.
screw retained. You were worried to make them screw retained, so it's wonderful. It's really
perfect. It's perfect. And then of course we can copy this emergence profile, send it to the lab, so he will match the exact emergence profile to fit on the soft tissues.
That's another important issue. You don't want your prosthodontic work to mess up with the papilla that you were able to preserve.
Exactly. And like you can see again, in the CBCT, we have the palatal bone preservation.
Well, because of the
because
ostial, because you left there, you have bundle bone, and
we have periodontal ligament.
Periodontal ligament.
That is, supplying all the vascularization needed to maintain that cortical bone, and that ultra thin buccal cortical is again on this cut. We can clearly see it that it was well preserved.
Yeah, it goes well above the neck of the implant, and there is no bone loss as the one we could see in the histology from Balmer.
It's remarkable, I think.
Yeah, it's very, very nice.
Well, and when patients want to smile, but they need a full arch rehabilitation over implants.
Yeah, and they just can't smile.
Well, I think the papilla, the Z factor management gets even trickier. Don't you think so, Felipe?
Yeah, I do, and especially on cases that are an ancient fixed bridge, and everything is decaying. And you have collapse of tissues, there is no lip support, there is a thin ridge.
We have bad occlusion.
Well, the occlusion is really, we have a deep bite and the occlusion is not good. So you have to totally rebuild it
And we've
from
seen
scratch.
also from the aesthetic part, there was a cant.
Yeah, maxillary cant. So you
Exactly.
got to handle all this in your rehabilitation. You have to diagnose it and you have to plan according to it.
So the difficulty level of this case is tremendous. We all know that.
Yeah, it increases. So that's why it's so important that you plan it. And that's why we, in all our cases, we go through this semi-adjustable articulated, mount the casts, and then see
facial
what's
bowl.
facial bowl, and see what you really need to do to change everything.
Totally agree. That's our project, our treatment plan project.
So we have a project, and happily, this is a case that is now 9 or 10 years, and happily, immediate load was really game changer. So it is now possible for our patients on the same day of the procedure
Of course.
and
Same
stay
day
with
teeth.
teeth.
Same day teeth. That everybody loves.
Stay with teeth, and we keep doing it from there.
But even more important, Felipe, is that you provided same day teeth, but you provided excellent soft tissue thickness, even 10 or plus years ago. Look at that amount of keratinized soft tissues that goes on the buccal aspect of your implants,
Yeah, it's
of the
nice.
patient implant.
We tried to really get the hand on what was good and not spoil what was good, and to reflect some of the palatal tissue to the buccal in order to protect our bone and have a nicer keratinized tissue, as you can see when we go
That's
to
why it heals
final
like-
impressions.
That's why it heals. That's why it heals like that.
So it's very, very important. And in many of these cases, you had huge collapse. The patient didn't want to go through block grafts. He was not even living here in Portugal. And so we needed also buccal support. We needed lip support also. So we had to go to artificial gingiva. If it was nowadays, probably we would do a little bit different. But
Yeah, but in more extreme and severe atrophy, maxillary atrophy, we know that lip support, it's very important. Once again, we need to get the smile from the face point of view, and we cannot only think and look to teeth, to implanted teeth. We need to see how they reflect into the face aesthetics. And so we know that many times we need to compensate for the bone loss with artificial gingiva.
yeah, sometimes you really have
You
to
really
do
have
it.
to do it.
Sometimes you really have to do it, and as was the case in here. Of course, you also have to take care of the occlusion. So in this case, we also did some minor orthodontic treatment. There we go again.
There we go.
That's why we love so much orthodontics, because it's really
It's so
a
handy.
fundamental tool to handle occlusion and space management. It's absolutely incredible. So minor orthodontic treatment, and that allowed us to go to full lower mandibular rehabilitation, and it made everything a lot easier.
Totally.
Do you think we could do it without orthodontic
Not at all. Not
treatment?
at all. We all know that if we don't manage, even by placing or putting teeth on their correct locations, we will be able to be much less invasive, because we don't have to correct misangulation of teeth with the prosthodontic rehabilitation. So we are allowed to cut less when preparing teeth for veneers, crowns, or what
Yeah, as in this case, that
Rehabilitation.
is a very, very important issue that he mentioned. The fact that you position the teeth into a more proper position, that will allow you to be much less invasive when preparing the teeth for veneering or crowns or whatever. So that's very, very important to take care of that part. And you
look,
can see occlusion.
What an amazing change, you know. So in this case, of course, I think our issue is, of course, to solve this malocclusion, and by enhancing function, we will get the bonus of getting an aesthetic enhancement.
Yeah, nice aesthetics. And you got a patient that he really didn't want to smile, and now he's very, very happy.
For sure
man.
he is.
He's a very, very happy
doubt,
man.
no
So, and you could handle, as you well said, occlusion. So that's important that you go always going for function will take you to aesthetics if you do it properly. I think. I don't know. What you think.
I totally agree, and you can see by the look of the patient that he will be radiant and very happy with his new smile and function.
Yeah, that's very, very important.
You know, sometimes, Felipe, patients don't want to undergo through major surgeries, like blocks, but others, they really cannot do it because of their health condition. And so this is when a less invasive procedure is considered a more valuable procedure to the patient.
Yeah, you can see that he is hypocoagulated, anti-aggregated. Well, general condition is really severe. So.
Yeah, he had some valve substitution, heart valve substitution. So it's a 77-year-old patient. So the question is, could he survive a more severe or complex surgery? Or could he be injured by that, harmed by that?
And he's going to be a bleeder for sure. He's
Totally bleeder. So as less incisions we can do, the better. So in this case, of course, first we need to set up our prosthodontic goal, to set our implantology. We need it to be guided by the smile of the patient. And again, like we said, we like to start in the manual wax up, but of course we can be very handy with a digital.
You can pretty much fuse together the both.
Again, fuse them.
Yeah, both approaches, digital and manual. And I would say, and this is a very nice case to illustrate that, one of our starting points is the central incisor.
Sure.
Once you place them, the central incisor, you can do almost the rest.
For sure. That's why we just waxed up until canine, because
it's beautiful.
This is our frontal view.
I love that
The rest
approach.
will go on with normal implant to implant or implant to teeth distance. So we set our prosthodontic goal, our project, and then we need to know what risk are we facing on trying to maintain, or if we need to rehabilitate, rebuild the transition zone. And for that, again, we need to go to the CBCT and evaluate the socket type and all the risks, the thin buccal bundle bone, and as we can see, in pretty much all areas we have very, very thin buccal bundle bone. Once again, we know that it can be torn apart during an extraction. It can resort when we remove the periodontal ligament. So this is indeed a risk factor when we are thinking on immediate post-extraction implant placement.
Yeah, in fact, in this case, on almost every teeth, you got the labial plate is fused to the root. And also you have cysts, so
and big cysts.
And big cysts, so you're talking about a huge risk on going through a socket type 3 or 2. So if you don't manage it well, it will be a defect.
So this is the typical case where if we can avoid extracting totally the tooth or the teeth, we can be saving a whole lot of problems.
Yeah, and especially because of our patient's condition, and also
so
the kind of collapse that you're going to experience if you extract those teeth.
Typical win-win situations to apply the partial extraction therapy technique. So we start on this baseline, this initial situation, and then instead of extracting those those teeth and those roots, we prefer to do socket shield on the implant, the immediate implant placement areas, and pontic shield to preserve the pontic area anatomy.
So you're going to be utilizing actually probably the embryo of the socket shield. You're going to be doing also root submergence technique in some of
It's the pontic. It's
the
an
pontic
evolution.
shield.
The evolution of the root submergence is to do pontic shield. What is the main advantage is that if by any chance in the future you need to place an implant in that area, you will not need to do some partial extraction because it was already done before. So you will have the original anatomy maintenance, and we will have bone if in case we need to implant to place an implant in there.
That's nice, and you prevent collapse.
We prevent collapse. We also want to give the same day teeth to the patient. We want to provide soft tissue support, and that's another major advantage of the immediate load provisionals. They will give immediate soft tissue support, so we are immediately taking care of the emergence profile.
I would say
Soft
that
tissue emergence profile.
I would say that whenever you're talking about immediate load, provisionals are a very important part of it. Would you say that?
I think they are
So
a crucial part of it.
we got to take good care of.
Good care of it, and especially we need to make sure that this bridge has a passive fit.
Yeah, that's
Good adaptation.
and that could be difficult when you're talking about splinting several implants. So you gotta utilize the right tools. You gotta use special abutments that allow for a much better passive
Yeah, for
fit.
sure. In this case, we are talking about transepithelial abutments, the multi-unit abutments that in our brand are called multi-im abutments, and that will, of course, make the passive fit topic pretty much easier. And this will allow us to start from the left picture showing surgery day to the right picture that is approximately 7 months with a very interesting soft tissue healing, maintaining really well, all that width. So we preserve the bone, the Y factor, we preserve the soft tissue, we enhanced it, and by using the adequate provisional shape, we were able to do all these emergence profiles that we know are crucial to make that natural look on the implant supported teeth.
I would say that the picture on the right really tells you how important it is that you take care of your provisionals, because you really could design all that emergence by taking care of your provisionals.
I totally agree. So, because we really take provisionals in a big account, we offer this patient the second set and high aesthetics PMMA CAD/CAM made provisionals, so that we could enhance even more the emergence profile and also check for occlusion, check for some, tooth morphology integration, and that goal, our goal was to get the exact shape that matches, soft tissues emergence, tooth morphology, and occlusion.
Yeah, despite or
With the provisional.
with the provisionals, because on top of everything, you did not just give support to the tissues, but you were also able to shape the tissues further to the shape that you wanted them to have, and to provide for a very natural emergence profile.
Natural emergence profile, and also easy to maintain and hygiene, which is crucial
hygiene
in a
is
very,
crucial.
very elder patient.
Yeah, and in extensive cases, if you're talking about full arch cases, it's so very important
It's
that you have the possibility of doing a good hygiene.
And when we achieve this final shape and morphology of our full arch bridge, provisional full arch bridge, we just need to copy it and transfer that shape to the full zirconian bridge.
Yeah, and you can see there the design.
Extremely well polished,
Yeah, the part that goes that faces the gingiva, it's not retentive. It's really easy to clean for a patient, especially with this age.
It's a biology carrying
yeah,
processes.
every detail matters in this.
And by doing that, we can develop a very interesting transition zone with multiple papilla in between implants in the pontic area, and all of this because we use the adequate technique. We went for the PET, partial extraction therapies techniques.
Look at that root effect. It's really beautiful, and the papillas, it's really nice.
Once again, in a very less invasive way, we can achieve a very interesting result. So we can get the adequate transition zone maintenance. This is the case set in the mouse. And in here, we can see a CBCT control where we can see the areas where we place the immediate post-extraction implants with the socket shield, the areas of the pontic shield where we have a pontic site preservation by maintaining a partial root fragment in there.
And look to the bone levels. They are really good. They're well above the neck of the implant.
On the opposite that we were used to before,
Yeah.
where the bone literally wanted to escape, and recess and normally resorb until that, physiological first thread resorption, bone resorption,
Which means that you didn't have the negative remodeling that we used to have when we extract the entire tooth.
we have the positive remodeling.
Yeah.
And that
Nice.
will translate clinically with a very aesthetic transition zone. And so this allows us to come from this initial baseline to this very interesting final result in a very less invasive way, but with a very interesting outcome. So, as a take-home message, we would like to talk a little bit about the periodontal ligament that we are really believing today that is a very important tissue that plays a very unique role on maintaining or not, or on the possibility of maintaining or not the buccal bundle bone. And well, we also know that from Araujo and Linde since 2005, so it's not a big surprise, but indeed that keeping or providing the chance to maintain that tissue without totally extracting the root, well, it can be game-changing in maintaining, an aesthetic transition zone.
And it's been 12 years. And the importance of this is that we're talking about the most ancient procedure in dentistry. And this is so very important even for young dentists, because next time you extract a tooth, one of your questions should be if you should extract the entire tooth or not, if you should keep one part of the tooth or not, if it's worth to keep one part of the tooth.
Yeah, totally agree. I think every day we are more certain that maintaining, part of the tooth, if not the whole tooth with an O-shield approach, the 360 degrees shield, is an adequate way to maintain the bone. And the literature is supporting that. Even in this very recent 2017 publication from Danny Bomer, that is a retrospective, a 5-year retrospective study, and that is showing that all these cases where they used the socket shield, well, they had a mean marginal bone loss of 0.3 millimeters, which is clinically not even detectable.
Almost nothing. We're talking about a recession that could be a recession around the lateral tooth, even without doing anything.
Totally agree.
Physiological recession.
Physiological recession. But, if you think that this is a very recent technique and that there is no literature on it, you are very well mistaken, because, the partial extraction therapy is more than 10 years old. It started with Dr. Sionpras in 2006, publishing the first root membrane publication.
And it's really impressive because then we had the RST, the root submergence technique by Salama.
Dr. Salama in 2007.
Maurice Salama and Emre Salama in 2007 published it.
Then Husler, with his famous, proof of principle, came with the first publication of the socket shield.
With histologic results. There was histology for the first time, and histology was pointing towards a very, very nice result in terms of preserving anatomy.
Totally. And it was so nice that Dr. Ken in 2012 published to try to apply this strategy to maintain the papilla in between teeth and implants. So we call it the proximal shield.
Yeah, and there was Balmer again, and also histological results about longitudinal fractures, which is a usual clinical set that we have to face in our offices. So you can do it also in longitudinal fractures.
With the adequate technique, so you should read the article. In 2014, Dr. Siompras again came with a 5-year data on the root submergence, which is, the name that the Greek group calls the socket shield. In 15, Dr. Mitzia came with a step-by-step of the root membrane technique.
So what we see is that there is huge literature and scientific evidence nowadays.
Going on with Gluckman in 2016, showing the proximal shield, that adaptation, that evolution from the root submergence technique
to better preserve the papilla in between implants.
No, the proximal shield.
Oh, proximal. Yeah.
It's not. It's to being able to place an implant if you need after maintaining the pontic site. Then this study that you've seen, the 5-year data of Balmers and Fortucam in the end of this year or in the beginning of the next year, the human histologic.
Yeah, that's going to be huge.
Is going to be huge. And finally, Dr. Gluckman and Jonathan Dutoit and Dr. Salama with that 128 socket shield cohort study.
A big sample from a multicentric study. This is really valuable data, scientific data that we're thrilled to have now.
And so I think this is supporting hugely our decision when we need to preserve and maintain the original anatomy in a less invasive way. And we know that if we do that, we will be one step closer to provide our patient with a nice and natural looking smile.
Yes, one step closer to natural. That's always our goal.
So that's it for today. We thank you very much. It was a pleasure for us to be here.
It was a real pleasure. Thank you, and hope to see you soon. And thank you the organization, because they did a tremendous job.
Tremendous job. We are going to stay focused and paying very close attention to all these amazing conferences, online conferences that are available to everybody around the world. So we are very thrilled to participate at the second edition.
Incredible lectures. And you have our email, so feel free to contact us. And
we hope to see you again soon. See you next time.
Soon.